It's sort of exciting for me to give these talks. I remember giving them back when we had sort of 3 data sets to go through, and obviously things have changed a great deal over time. Although we could argue that maybe they haven't changed so much too, in the sense that there's still a lot that we have to learn about immunotherapy. So we're talking about the frontline setting, and I think that in many respects you have to consider the Keynote-024 study to be the seminal study here. This again was a study where patients who had high PD-L1 expression, that was defined as PD-L1 of 50% or greater, were randomized to either pembrolizumab or frontline chemotherapy. There was crossover allowed, which many people thought would mean that we really would not have an overall survival advantage. But in the end, what you can see here is a very profound benefit with respect to both progression-free survival as well as overall survival in this data set. And that overall survival, again, was despite the fact that crossover was allowed. I show this because I know we had discussed earlier the question of whether to incorporate immunotherapy and chemotherapy or immunotherapy in these patients who have high PD-L1 expression. I show this just because this is the Keynote-042 study, which was done really outside the United States. And as part of this study, patients were not allowed to cross over, and most of these patients were in locations where crossover was really not feasible because the drug was not commercially available in those locations. This is the subset of patients from that study that had PD-L1 of at least 50%. And although one could say, well, this is a subset analysis, so it doesn't hold as much weight as the original Keynote-024 study, one thing to note is that this subset analysis of this larger study is about 2 times the size of the original Keynote-024 study. And I just point this out because whereas the Keynote-024 study, really, there's no evidence of a group that does poorly on immunotherapy up front. The numeric outcomes are really very good for the pembrolizumab monotherapy. They're a little less good in this study. So I think we should sort of think of the real outcome being somewhere between these 2 data sets when we sort of try and evaluate what the true outcomes for patients who have high PD-L1 expression is. Here you can see the overall survival, again, from that study, showing that really nearly half the patients are alive at 2 years. And what we've seen in the frontline setting is in this PD-L1 high group is really having a response, about 30% of the patients being alive at 5 years, again, specifically in this PD-L1 high group. So PD-L1 has remained the sort of mainstay of treatment approaches. There are basically, I guess, 2 other biomarker-based approvals. One is microsatellite instability, which we really very rarely see in lung cancer. However, we do have some patients who have high tumor mutation burden. This is from the original RISV article in Science, where they looked at patients who were treated at Memorial, as well as our patients at UCLA, looking at the tumor mutation burden, showing that this group does considerably better, those who have a higher non-synonymous tumor mutation burden or more mutations that change the eventual amino acid. This is also an approved indication across histologies for patients who have more than 10 mutations per megabase. And there are some times where in people's practice, they do treat these patients even if their PD-L1 level is not necessarily supportive on its own of frontline monotherapy. The one thing that I would, at least in my view of the literature, I think that tumor mutation burden, although it has been described in this data set here as sort of continuous, it's not really what I see. This is a little bit of a complicated slide, but is looking at the hazard ratio between PD-1 inhibition versus comparators as part of the lung map study. And what it shows is I think that there's a group of patients that the tumor mutation burden is not particularly predictive. There is a group on the left that has very low tumor mutation burden where you really don't see much benefit from immunotherapy in this setting. And then there's a group with very high tumor mutation burden that really does seem to have disproportionate benefit from immunotherapy approaches. One of the things that we're now trying to figure out what to do with is what to do in the setting of these relative biomarkers. So this is from a paper in Cancer Discovery by Scalise and colleagues out of MD Anderson, looking at STK11 or LKB1. and showing how it predicts, particularly in patients who have KRAS mutations. And what you can see here is that this group did particularly poorly with PD-1 inhibitor monotherapy. Now, I think it's a little bit hard for us all to know how to incorporate this into our treatment schemes. Many of us don't even have this data. If you don't get NGS, you won't have this data. And this is sort of a subset of a subset who are going to have an STK11 mutation in the setting of a KRAS mutation. And I think for many of us, we're still struggling with how to deal with this data.
So, could I just a basic question? When you have a hazard rate, for example, of 1.87, is that the same thing if you flip the curves? Is that the same thing as having a hazard rate of like 0.13? Because that I can
No.
understand, 87% reduction. So, like, what does it mean when you have a positive hazard rate? Like, how do you convert that to the way you
Yeah.
do the other way?
So that's an excellent point. So no, the way to look at it is that it basically 1 over that. So if you were to do like 1 divided by 1.87, that would be the hazard ratio the other direction. So that's going to be somewhere like zero point 0.6. Does that make
So you
sense?
can't really, yeah, no, but that really is helpful. So in other words, you can't really look at it this and come up with a percent the way you can when it's less than one. Like I said, if you have a hazard rate of point, 4, you can look at it and go, okay, that's a 60% relative reduction. But it's not percent wise here. It's more
Yeah.
1.2 twice, et cetera.
Yeah, each year I'm a little further removed from my MIT days, but I think so. I always hesitate that I'm giving you the wrong. But I think that the way to think about it is that it's one. So if you were to flip the arms, it's just 1 over that. So that
Right.
if you were to simplify it and to say that, so I think in this case it's going to be somewhere around when you look at it that way, because obviously 2 would be a zero point 0.5 if you were to do that, and so if you're 1.87, I think you're going to be close to zero point 0.6 here.
Got it. Okay, please continue.
Sure. So one sort of controversial data set is what to do in these patients who have PDL1 of 1 to 49%. In the Keynote 042 study that I mentioned earlier, where really there was no crossover, what you can see is that there really is not much difference between pembrolizumab and chemotherapy. However, because of the study design, which looked first at this PDL1 1% or greater cut point, um, in that group of patients, there is an approval for pembrolizumab monotherapy. I think that I, like most people in academia, are reluctant to give single agent pembrolizumab in the setting of PD-L1 of 1 to 49%. However, there are exceptions, particularly elderly patients, patients with more comorbidities. And I think that there is a group of patients that this will bring into the realm of treatment who may otherwise not really go for chemotherapy. They may not be willing to do that. So there is probably some place, but in my practice, at least, it's sort of a niche indication. Um, we tend now to look at more in the larger population at combinations. Here you can see data on top for overall survival and below for progression-free survival on the original combination of chemotherapy, carboplatin and pemetrexed in this setting, plus pembrolizumab, showing very profound improvements in progression-free survival and overall survival, really sort of looking across different groupings. Um, there are other chemotherapy-based approaches that have been evaluated. I'm not going to go through each one because most of them are conceptually quite similar. The one that I will go over is the Empower 150 data set, which looks at the combination of atezolizumab, bevacizumab, carboplatin, and paclitaxel. In this case, the addition of the atezolizumab to the other 3 drugs did lead to improved outcomes. And I think that we're still trying to sort out what the contribution of the anti-angiogenic is, which is bevacizumab in this situation. The numbers in cross-trial comparison look similar, making it a little bit difficult for us to know what the specific role of the anti-angiogenic agent is, but we're going to talk a little bit more about that later in the talk as well. So in addition to chemotherapy, the other addition is really looking at the combination of a CTLA-4 inhibitor. This is the schema for part 1 of the Checkmate 227 study. This is, I think, in my estimation, a very sort of complicated study design. I describe it as a 6-arm 4-bin study. The reason that I describe it that way, patients are broken down based on PD-L1 expression less than 1 versus PD-L1 expression of 1 or greater. Both arms have a nivolumab and ipilimumab arm. Both have a chemotherapy-only arm, but in those who are PD-L1 greater than 1, there's a nivolumab alone arm, whereas in those who have PD-L1 less than 1%, there is a nivolumab plus chemotherapy arm. When one looks at the original early time points, I would argue that it's very hard to convince yourself absolutely that there's a difference between the nivolumab, particularly in the PD-L1 positive patients where this is an FDA-approved approach, between the nivolumab alone and nivolumab plus ipilimumab. But over time, many will argue that there's that there is some increase that one sees over time. And you can see here's the data on the 4-year. We now have some updated 5-year survival. But you can see that in those who are PD-L1 less than 1%, you actually have a survival of nearly 25%, which I think is really quite good. This is really seen again across both squamous and non-squamous disease. The Checkmate 9LA study looks at the same immunotherapy combination of nivolumab and ipilimumab. The dosing and timing is slightly different, but compares that to chemotherapy alone. There were only 2 cycles of chemotherapy. Again, with updated data over time, you can see that that there continues to be a benefit to the addition of the nivolumab and ipilimumab to chemotherapy. The thing that, of course, complicates this is that the control arm of all of these studies are the same. We don't really have comparative data with chemotherapy and PD-1 inhibition versus chemotherapy, PD-1 inhibition, and CTLA-4 inhibition as part of this study design. We do see sort of a 3-arm study in the Poseidon study, which is the most recently approved combination approach. In this study, we looked at, and I was involved with this study, platinum-based chemotherapy alone versus platinum-based chemotherapy plus single-agent durvalumab, or platinum chemotherapy plus both durvalumab and, which of course is PD-L1 inhibitor, and the CTLA-4 inhibitor, tremelimumab. The combination of chemotherapy and durvalumab did not meet its statistical endpoint. However, the combination with both durvalumab and tremelimumab did. Here you can see the improvement of progression-free survival on the left and overall survival on the right. Again, as I mentioned, this data led to the approval. That being said, there was similarity between the durvalumab and chemotherapy, and durvalumab, tremelimumab, and chemotherapy. However, one did hit its statistical endpoint, whereas the other doesn't. One data set that I like to include in my talks on frontline management, I think is, and it's a little hard because many of these patients actually were previously treated, but gets at something that I think is a really practical issue that sort of gets overlooked, and that's how long do we continue these checkpoint inhibitors? Most of the data sets, so for instance, for pembrolizumab, stop at 2 years. Other data sets stop at 1 year. As these agents move into earlier stages of disease, we've sort of gone to 1 year. But I'm not sure we've settled this altogether. Here you can look at the Checkmate 153 study, a data set that I was involved in. This is sort of an interesting design. There were 1,245 patients treated, but the randomization actually happened at a year. So patients who were doing well at a year were randomized to continue with nivolumab or to stop nivolumab. This is what we describe as a randomized discontinuation study. And the data set here is a little bit complex, but if you look just at the intent to treat analysis, what you will find is that, in fact, the p-value was less than 0.05 in the intent to treat analysis for survival, favoring patients who continued indefinitely. And that gives me some reluctance in patients who are doing well to continue even at the 2-year mark, but obviously different people feel a little bit differently about that. So I think that in terms of sort of, what to do when patients progress after chemoimmunotherapy approaches, which end up being most of what we see, I think that most of the studies are randomizing to docetaxel. Here you can see a study again that I was involved in of adding ramucirumab to docetaxel. This is a bit of a complicated data set to go through, not because the study design was complicated, because it was not. It was just docetaxel with or without ramucirumab. But the benefit was real but modest, and there is some increase in toxicity from the perspective of randomized studies. Many have not required the inclusion of ramucirumab, and there are multiple studies that have yet to read out that are looking at a PD-1 or PD-L1 inhibitor along with a multi-targeted tyrosine kinase inhibitor that includes VEGF inhibition. But one interesting data set out of the lung MAP study, this is obviously an effort that's been going on for a long period of time, and has really struggled to find a data set that would be considered a positive data set. And this is, I think, really the first positive data set. Here they took patients who had progressed on frontline therapy and randomized them really to investigator's choice. They could choose docetaxel ramucirumab, and many of them did. Versus pembrolizumab and ramucirumab. Ramucirumab, again, is a monoclonal antibody targeting VEGF receptor. Here you can see the best objective response rate was really quite similar between those. The progression-free survival also fairly similar, although there may be a hint of a tail to this curve favoring the ramucirumab arm. But when one looks at overall survival, you can see that there was an improvement in overall survival when one looks at the regimen of ramucirumab and pembrolizumab as opposed to the standard of care. Now, this is technically clearly a positive study, because even though response rate and progression-free survival were not in favor of the pembrolizumab plus ramucirumab, the primary efficacy endpoint was overall survival, and that was met. And there's going to be, my understanding, a large cooperative group study to evaluate this further. Although immunotherapy has sort of been an area of great enthusiasm over the last several years, certainly there is also reason for enthusiasm about antibody-drug conjugates. There are multiple of these, and I'm just going to focus on datopotamab deruxtecan. Datopotamab deruxtecan is an antibody-drug conjugate that is targeting TROP2. This is, I would say, the most extensively studied of the antibody-drug conjugates in lung cancer. After a phase 1 dose escalation, 180 patients were treated with datopotamab deruxtecan. Here you can see the anti-tumor activity. This was a heavily pretreated group, and in light of that, I think that the waterfall plot you were seeing on the right is really quite impressive. You can see that the response rate in these patients was, if you take it all together, upwards of 25%. Duration of response also really impressive in the 10-month range, at least impressive in my estimation. And this has now been part of a study randomized versus docetaxel. We do not yet have results from that data. That figure that I showed before was looking at the whole group. Here we're looking at just patients with actionable genomic alterations. Most of these patients had EGFR mutations, and you can see in this group it was also quite efficacious with a response rate of 35%.
Can you talk a little bit more about Dato-DXd, particularly as it relates to tolerability issues? Of course, kind of has the same last name, so to speak, as TDXd, where ILD is an issue. Also, we hear with TDXd issues related to chemo-like side effects, nausea, vomiting, etc. What about Dato-DXd in terms of side effects and toxicities?
Yeah, so thank you for bringing that up. The ILD risk that we have seen with, for instance, trastuzumab deruxtecan is also seen here, and out of the 180 patients who were treated in this study, there were 3 cases of fatal pneumonitis, and that obviously is of significant concern. Interestingly, in this study, all 3 of the patients were treated at the 8 milligram per kilogram dose, which since has been discontinued. Now, does that mean we won't see such high rates now that in studies we're looking at lower doses? I think it is hard to know, and we'll have to see as we get data from that. Other toxicities that we do see some chemotherapy toxicities, as would be expected. A few unique toxicities that we tend to see: stomatitis, which our colleagues in other histologies do see more frequently, but we tend not to see it as much, is a real issue. And there are some ophthalmologic toxicities as well, which can be bothersome to patients.
I've heard about the stomatitis. I don't remember hearing about that with TDXD. Any particular reason why am I right that you don't, that this is maybe more particular? Does it have something to do with TROP2? And what do you see clinically? And how easy or difficult is it to manage?
Yeah, I guess my bias we've used more datopotamab deruxtecan. I think we've seen some mucositis as well with trastuzumab deruxtecan, although maybe a little more with the datopotamab. I think that we're starting to sort of prophylactically look at things like steroid rinses and things like that. But my hope is that just like when we talk to people who were around during the development of cisplatin, and you would have these terrible toxicities of renal failure that then were able to be addressed by fluids. I think there's certainly a hope that as we get further into the development of these agents, that we'll be able to have that improve.
So you mentioned ophthalmologic issues. We actually just did an entire program on ophthalmic issues in oncology because we hear so many issues about that with ADCs in particular. And of course, this is an ADC, but we see all kinds of ophthalmic issues. What do you specifically see with this agent?
Sure. So I've been involved with several studies back years looking at this. And what I would say is it's very hard for someone looking at the data to figure out what's going on. Part of the issue is that medical oncologists are terrible at rating or assessing ophthalmologic issues. The same event would be listed in a different way by multiple different investigators. So one thing that we see, which I think is not as problematic, is dry eyes. There you can use, drops, and most patients don't bother that. That doesn't bother them that much. There are patients who have more substantial effects where they actually have some decrease in their visual acuity. Now, it's always a bit of an interesting thing because we tell people, and this is true, that it will resolve when they stop the drug because the drug's sort of keeping them going from an efficacy perspective. So I think it's a little bit difficult.
So I know, you don't want to try to, no one wants to predict the results of an ongoing randomized study, but I am curious, just based on your clinical experience. I mean, docetaxel is not the easiest drug to use in this particular setting. Any thoughts about, sort of based on your own experience and the data, just how the toxicity and side effect data is going to compare docetaxel versus Dato-DXd?
Yeah, I sometimes have joked, although I'm not sure it's a joke, that probably the majority of doses of docetaxel, 75 milligrams per meter squared, given for lung cancer in the United States, are given on clinical trial. I don't think the practitioners have a great love for this regimen, and I think that the real question to me is not which one is more well tolerated, because I think the answer to that, in my experience, is clearly datopotamab deruxtecan. I think the question is, when one grades things, how it will come out. For instance, you can be very confident that you're going to have more high-grade thrombocytopenia in the docetaxel arm. But you will have a lot of these low-grade stomatitis, and so I think that what you're going to find more is that there are different toxicities. That in fact, it's probably going to be a little difficult to compare these really directly one to the other. But I think if you talk to people who are part of the studies, I think that they will tell you that they found the datopotamab deruxtecan easier to give.
And of course, this comes up with TDXD. If you have a potentially lethal side effect, that changes the equation considerably. I can't quite figure out about Dato, the magnitude of the ILD issue. There's not as much data. It kind of seems like there's not as much ILD, but I don't know whether you can really say that. In general, how would you follow a patient getting a Dato DXd related to the lungs? Of course, in lung cancer, a lot of them already have lung problems, whether it's a tumor or underlying disease. In breast cancer, they're very aggressive about doing imaging on these people, trying to pick ILD up imaging-wise before their symptoms. What's going to be, or what is the approach with Dato DXd?
Yeah, to date in our clinic, we've really focused more on patients who are having sort of clinical symptoms, and to be very vigilant and make sure they know to let us know should these events be occurring. To me, this is actually going to be a much bigger challenge when one moves up into earlier settings, assuming that that happens, right? So most of the patients on the datopotamab deruxtecan study had received at least 3 prior lines of therapy. A low but real toxic death rate in that setting is not great, but acceptable. In the adjuvant setting, it's not acceptable. And I think that that's going to be something that we'll grapple with as development of these drugs move forward.
So one other thing about antibody drug conjugates, but specifically Dato DXd, we're hearing a lot about the idea of combining ADCs with IOs. And GU and bladder cancer, they're all excited, the investigators there, about enfortumab, the antibody drug conjugate combined with Pembro. A lot of the GU investigators think that's going to be first-line therapy. I saw these data looking at Dato DXd combined with Pembro, just kind of, and platinum chemotherapy. Just kind of curious what your thoughts are about that, whether you see much of a future combining ADCs, specifically Dato, with chemo and IO.
Yeah, so I think that it's going to be that you can see there's this data set looking at datopotamab deruxtecan with with PD-1 inhibition. You see similar data with sacituzumab govitecan, which of course is another antibody drug conjugate targeting TROP2. And I would say that when one looks at this data, it's supportive that you certainly can do it. I think the question that's going to come up, and I think we're going to have to sort out, is we already can give chemotherapy with PD-1 inhibition in a frontline setting. So I think the big question is, what are you trying to replace in this setting? Are you trying to replace carboplatin and pemetrexed? Are you trying to replace pemetrexed? In squamous disease, are you trying to simply replace the paclitaxel? And I think that we're going to view over time what that is. And part of this is that the toxicity profiles of these agents are different. So I think that there may be more satisfaction with carboplatin and pemetrexed, and people may not be in a big hurry to replace that. And I think that we'll see where the efficacy and toxicity data fall as these trials move forward.
And I see that it's also being combined with Pembro, I guess, in PD-1 high patients. I guess that's kind of like giving chemo with Pembro, but maybe better tolerated. Any thoughts about that strategy?
Yeah, again, I think it's it's something that is interesting, but as you point out, we already can give chemotherapy with pembrolizumab, and that's an approved approach. So I think that when one looks at this data, the real question from my perspective is the anticipation that it will beat standard chemotherapy in this setting based on efficacy or based on tolerability, and I think that we still need to prove both of those.
You mentioned sacituzumab, and I was talking about bladder cancer because sacituzumab is approved there and also in breast cancer. What do we know about sacituzumab in lung cancer compared to, for example, Dato DXd?
So we don't have nearly as much data on sacituzumab govitecan. Interestingly, when people look at the data, they generally are citing a paper by Dr. Heist from 2017 that looked at the sacituzumab govitecan in a basket trial, and they did have somewhere near 60, I believe, lung cancer patients. And the response rate in that study, I believe, was 17%, which is certainly respectable. As you know, in the intervening time, they've looked in other settings and have had approvals in triple-negative breast cancer and urothelial cancer, but it is now being actively explored as well in lung cancer.
Is it active enough that you have ever attempted to get it outside the indication in lung cancer?
So I have tried to get it in an outside indication in lung cancer, and what I would say is it was, in my experience, very difficult. We had a patient, for instance, who was continuing to respond to, on trial to datopotamab deruxtecan, but ended up having to come off, and the patient wanted to try to get sacituzumab govitecan. We were not successful in getting it.